The following are the clinical pictures showing the lesions of Lichen planus. Coming to the epidemiology of Lichen planus. It involves individuals in the age group of 10 to 40, that is, the adolescents and the middle age group. There is a sex preponderance of females more than males. The etiology of Lichen planus is multifactorial. In most of the patients, in spite of thorough investigations, we are not able to find the etiology. In some patients, drugs are known to trigger the lesions of Lichen planus. Many times, contact sensitization may also lead to Lichen planus, as in the case of oral Lichen planus caused by the mercury dental amalgam. In some patients, hepatitis C is also known to trigger the lesions of Lichen planus. Many patients who receive transplants develop a graft versus host reaction and tend to present with lesions similar to Lichen planus. There are 5 P's which are very important in the clinical features of Lichen planus. They are the following: pruritic, polygonal, purple, plain papules. The sites of predilection of Lichen planus are the following. It usually involves the flexor aspect of the wrists, extensor aspect of the thighs, extensor aspect of the legs, and extensor aspect of the dorsum of limbs. It can also involve the sacroiliac areas. Now coming to the symptoms of Lichen planus. Patients present with very itchy skin lesions. The oral lesions may be asymptomatic, or patients may have an excessive burning sensation, especially when they take spicy foods. Wickham striae is the classical oral manifestation of Lichen planus, in which the patients present with reticulate, white, lacy pattern in the buccal mucosa. Koebner's phenomena is a very important phenomena in the pathogenesis of Lichen planus. What it means is, in an area of normal skin, if there is trauma, lesions similar to Lichen planus elsewhere develop, mostly in a linear fashion, as seen in these pictures. Lichen planus can present in a variety of ways. The following are the variants of Lichen planus. First, annular Lichen planus. The patients present with hyperpigmented flat center and violaceous elevated peripheral lesions. The lesions may involve the face and the glans penis. Actinic Lichen planus. Patients present with annular lesions with a thread edge and a perilesional hypopigmented halo. The lesions are predisposed to occur on the face, the dorsolateral aspects of the upper extremities. Coming to the linear Lichen planus. In this, the lesions, mostly papules, are arranged in a linear fashion. The extremities are the sites of predilection. Follicular Lichen planus. Patients present with perifollicular violaceous papules that may also lead to cicatricial alopecia if the lesions are present on the scalp. Scalp, trunk, and extremities are the most common. Hypertrophic Lichen planus. Patients present with a central depigmentation, verrucous hyperkeratotic papules and nodules, mostly involving the shin, which is the extensor aspect of the leg. Bullous Lichen planus. Patients present with bulla formation and the lesions are most likely present on the extremities. Now coming to the histopathology of Lichen planus. Any patient who is a suspect Lichen planus, we need to do a biopsy to confirm the diagnosis. After the biopsy, the specimen is subjected to a pathology processing. The findings revealed are a thickened granular layer. There is degeneration of the basal cell layer, which creates the Max-Joseph spaces in the lowermost layer of the epidermis. There are colloid bodies which are seen in the upper part of the dermis. There is sawtoothing of the dermoepidermal junction. And there is a band-like upper dermal infiltrate which is considered classical for Lichen planus and is known by its name called as lichenoid infiltrate. The nail lesions of Lichen planus are characteristic. There is extension of the proximal nail fold onto the nail matrix and the nail plate, and this is known as a pterygium. The sign that it creates is known as a pup tent sign. If Lichen planus involves the scalp, it may lead to scarring alopecia with destruction of the hair follicles. Now coming to the treatment of Lichen planus, which can be categorized into the following. For localized Lichen planus, topical steroids of the medium potency are effective, and we may add oral antihistamines if the patient is having excessive itching. In patients who have extensive Lichen planus, we may give them psoralen and UVA along with oral steroids, may or may not without acetretin. In patients with hypertrophic Lichen planus, potent topical steroids like clobetasol are usually combined with salicylic acid, and antihistamines are usually added in such patients because the lesions are very itchy. In patients who have Lichen planus of the nails and scalp, oral steroids are started on diagnosis. In patients who present with erosive mucosal Lichen planus, dapsone, oral steroids, and acetretin may be used. A new drug on the block for erosive mucosal Lichen planus is cyclosporin.